Yeah. Hello.
Yes,
Hello.
yes, sir.
Yeah. Good morning once again. And we are supposed to discuss the calcium homeostasis in the continuation of the previous class. Two class completed, but couldn't finish the hemostasis with all the condition and whatever it has been mentioned in the curriculum. So couldn't finish. Today supposed to finish. Uh, let's see if we will start soon and without any interruption. We are able to finish the when suppose calcium homeostasis. We had a talk so many points with the factors. What are the factors responsible for to maintain the calcium level in our blood or in our body? And after that, one point is there: when you are being a doctor, when you are being a physician, when you are supposed to check the calcium level, what are the conditions? When you are supposing patient is coming to you, and all the patient, you cannot check the calcium level, phosphorus level, phosphate level, or any other sulfate level. But when calcium, what are the condition, what are the suspected case to check the calcium level? So these are the important points. If you will keep in your mind, that is most important. One is first neurological symptoms. If any neurological symptoms, irritability, seizures will be there, this is the first point to check the calcium level, serum calcium level. Second point, renal calculi. If any problem will be there, you can check ectopic calcification. If it is there, that also one of the factor. Suspected malignancy, this is also one of the factor. Polyuria and polydipsia is also one of the point, and chronic renal failure, this is the major point. And last point, prolonged drug treatment which may cause hypercalcemia, that vitamin D, which is known by calcitriol, thiazide, diuretics. These are the point when you are supposed to, being a doctor, supposed to check the calcium. Now, this slide might have discussed earlier because starting, I cannot move directly. So that's why now I come to know that phosphorus, this also might have discussed multiple biological function of phosphorus. These are the important functions for phosphorus. Along with the calcium, you must check the phosphorus also. So multiple biological function, on the basis of function, you must know what is the function, what is the relation in between calcium and phosphorus. So first of all, what are the biological function? Formation of bone and teeth. This is also along with the calcium. This is helping with the calcium for formation of bone and teeth. Production of high energy phosphate compounds, example ATP, CTP, GTP, creatine, phosphate. These are the energy phosphate compound, high energy phosphate compound, adenosine triphosphate, guanose and triphosphate, cytosine triphosphate, and creatine phosphate. These are the high energy phosphate compound. So this is also one of the cause. Synthesis of nucleoside coenzyme, which is very important. That one is known as NAD and NADP. Formation of phosphodiester bond during DNA and RNA synthesis. These are the function. And two more functions are there, three more functions are there along with the calcium. They are doing activation of enzyme of phosphorylation. You might have heard the name of phosphorylation reaction also in the different metabology, and supposed to discuss in the next metabology also. So formation of phosphate ester such as glucose 6-phosphate and phosphate buffer system in the blood. These are the important function of phosphorus, or we can say biological function of phosphorus along with the calcium, which are very much helpful. So in the phosphorus, how it is distributed in our blood, in our body. So 85% skeleton in the form of hydroxy apatite, and 50% extra skeletal, they are keeping, and they are in the form of phosphoprotein, phospholipids, and nucleic acid. In these three forms, they are found. They are in our body. So among the only 15%, but 85% skeletal in the form of hydroxyapatite form. This is the distribution in our body in the form of the phosphate. Now, blood phosphate, this is the blood concentration, how you can check in the blood and how much concentration in our blood and what is the reference range and ionized form, protein bound and complex form, what is the percentage as much as possible. But first of all, blood phosphate, we used to know generally S2PO4 and HPO4 in the form of, and blood concentration and generally reference range and normal value 2.5 to 4.5 milligrams per deciliter. This is the concentration, this is the reference range, and this is the normal value of phosphate or phosphorus. In three category, it may be in our blood, 55% in the ionized form, which is known by free form. Protein bound 10%, whereas complex form 35. If we will compare with the all 55, 35 and 10 altogether, 100% will be there. Up to this slide, we might have discussed in the previous class. Now dietary phosphorus. What are the dietary phosphorus? Widely distributed phosphate food additives. We are taking every day diet, but how much phosphorus is there, how much calcium is there, how much other traces elements are there, how much vitamins are there, which are very much useful for our body for general integrated metabolism for the function in our body. So first one is widely distributed phosphate food additive, whatever we are taking, but only 1 gram per day is required for our body. You might have discussed, and we might have discussed in the trace element also, how much is required per day and where it is distributed, in which diet it is there more amount. So absorption, what are the site? Distal or duodenum, this is the site, and mechanism only calcium dependent and calcium independent. On the basis of calcium dependent and calcium independent, this is the phosphorus. That's why I said you, along with the calcium, they are working together, along with the calcium. That's why in the examination also, in the practical, inorganic substances in the urine, we used to taste like what are the organic and what are the inorganic substances. Along with the calcium, whenever we are checking the calcium, how much calcium is excreted normally in the urine, we are supposed to check. And along with the calcium, not only calcium, phosphorus also, we must check how much it is excreted along with the urine. That's why along with the calcium, I've given the phosphorus level also and phosphate level. And so site, distal or duodenum, mechanism calcium dependent and calcium independent in both the condition. Regulation, how it can be regulated? With the diet, 70% absorbed. With the diet only 7. That's why if you are not able to take the less than 30% or 10% if you are taking, you may suffer some of the disease, whatever it is along with the calcium, related with the calcium disease in our body. So parathyroid hormone or some other things, whatever we had discussed related with that calcium. So 70% is required and in the diet, and it will absorb in our body up to 70%. Calcitropic hormones, this is the helping hormone which is very much helpful for absorption of phosphorus along with the calcium. And vitamin D, calcitriol, it will increase, and PTH also increases and calcitriol decreases. Three conditions: vitamin D, calcitriol increases, PTH increases, and generally calcitonin decreases. These are the very much helpful for regulation of phosphorus. Other factors which are responsible for absorption, GH also, it is increases, phosphate binder, calcium L decreases, calcium decreases, and fecal excretion, none absorbs and secreted. This is the point for the phosphorus along with the calcium, urinary phosphate. major route of regulation urinary phosphate related to diet 90% with the filter, proximal tubule 90% reabsorbed, H2PO4 active and HPO4 passive, which I have seen shown to you in the previous slide in the beginning, and distal tubule 10% reabsorbed in this condition apart with the urinary phosphate. Now regulation along with that one, you have to regulate diet, calcitropic hormone, PTH increases excretion, CT increases vitamin decreases excretion, which has been given to in the previous slide. That one is very much helpful for the PTH, calcitonin, and vitamin D. Now, when the check the phosphate level, you have seen the one separate slide for when to check the calcium level. These are the conditions. When you are supposed to check, being a physician, supposed to check the phosphate level also, renal tubular disease. This is the first condition. You are supposed to check the phosphate level. Hyperparathyroidism is the second condition to check the phosphate level. Hyperparathyroidism and hypoparathyroidism. This is both the condition. Any bone disease such as rickets example, muscle weakness, renal failure, these are the condition. In these condition, if any patient, any person is suffering from these conditions, any of the condition, you are supposed to check the phosphate level along with the calcium also. Do you have any confusion?
No, sure.
Now, parathyroid hormone, several times we had discussed about that PTH. So what do you mean? This is the, depends upon the PTH. These are the factor which we had discussed in the beginning, depending upon the parathyroid hormone, this is the regulatory factor to increase the absorption, PTH, to regulate the calcium level in our body, to maintain the calcium level in our body. That's why we are calling this the calcium homeostasis. About the parathyroid hormone synthesized in the 4 parathyroid glands as a pre-pro PTH consisting of 115 amino acid precursor giving a 90 amino acid pro-hormone after removal of amino terminal leader sequence 25 amino acid. These para should underline because these are the question for MCQ in the final examination. Final exam, better to underline. So pre-pro parathyroid hormone consisting of 115 amino acid. 115 amino acid precursor giving a 90 amino acid as a pro-hormone after removal of amino terminal leader sequence under bracket 25 amino acid. Okay, further clipped at 6 oblique -6 -7, leaving 84 residue in the mature peptide, especially for the parathyroid hormone. This is the mechanism behind that. Now you can see this is the mechanism. This is the full biological active sequence with the pre-pro parathyroid hormone leader. This is the pre-sequence about that. This is the, and all the amino acid are relatively consist of this one. Now, no need to draw this one. Now, parathyroid hormone is still continuing. So, regulation of calcium homeostasis, we are talking about on the basis of calcium homeostasis. So, parathyroid hormone, this is the important regulation of calcium homeostasis. Sorry. Hello. Hello.
Yes, sir.
Yeah, sorry for disturbance. So, still continuing about that parathyroid hormones on the basis of calcium homeostasis, which are discussing continuation. So, regulator of calcium homeostasis. These are the factor biological activity resides in the first third N-terminal region of intact PTH. And this is the mechanism. Oxidation of methionine residues at a position 8 or 18 result in loss of biological activity, which we have seen in the previous diagrammatic representation where you have seen, sorry, this one. So you can compare with this one of this one. This explanation is here. So regulation of calcium homeostasis, biological active resides in the first third. You can compare with the diagram, terminal region of intact PTH. Second point, oxidation of methionine residues at position 8 or 18 result in loss of biological activity. Fourth point, PTH contains large number of basic amino acids, whereas the middle portion of the molecule is immunogenic because of its hydrophobicity of specificity. This is the continuation of the parathyroid hormone about that. Circulation forms of PTH, how it can be circulated in our body, how it can be circulate PTH, which is playing vital role for calcium homeostasis. So this is the parathyroids. It is in the blood intact with the PTH, and second terminal, this is the carboxyl terminal fragments. Carboxyl terminal fragments. PTH will go to the liver, whereas carboxyl terminal fragment, it will go to the kidney. Along with the intact PTH, it will affect with the kidney. So intact active PTH of 84 amino acid, this is the first point along with this one. Inactive carboxyl terminal fragment lack the 134 active domain, and PTH T half life is 2 to 3 minutes only, 2 to 3 minutes, whereas liver 2/3 and kidney 1/3 are major site for fragmentation. So in the both the condition, you should underline what is the half life for the PTH. Liver and kidney also you have to mention, underline this one. This is the MCQ question. How the PTH can be circulate in our body? So parathyroid hormones in the first intact PTH in the blood, then carboxyl terminal fragment, it will go to the kidney, and intact PTH will go to the liver. With the liver, carboxyl terminal again. So this circulation and intact PTH, it will come to the, this circulation will continue, otherwise difficult to maintain the homeostasis, especially for the calcium homeostasis. Now, regulation of PTH secretion and biosynthesis, how it can be regulated and how it can be biosynthesized. So extracellular calcium regulates secretion of PTH first. Extracellular calcium regulates secretion of PTH. So how it can be, what are the effect for that? Low calcium level increases. Low calcium level. If extracellular calcium regulates secretion of PTH, first of all, if person or if patient is, sorry, if low calcium increases and high calcium decreases. Calcium also regulates transcription. High level of calcitriol inhibit transcription. And chronic severe hypomagnesemia in alcoholism patient impairs PTH secretion, whereas acute magnesemia may stimulate secretion. This is the mechanism behind, and hypermagnesemia suppress PTH secretion. All the points, whatever it has been given, is the MCQ. Total 10 question, including this slide. 10 question are there. So better to reserve this the regulation of PTH secretion and biosynthesis. So reserve for this the MCQ question for the examination. Now, calcitonin, what is this? This is the one of the factors to maintain the calcium level for our homeostasis. So product of parafollicular calcium C cells of the thyroid gland, 32 amino acid including. This is the sequence of human calcitonin, and molecule contains 7 members linked by a disulfide bridge at the N terminal. You can see the N terminal, all these things. So 32 amino acid. Third point, inhibits osteoclasts, and inhibit osteoclast mediated bone reabsorption. Mediated bone reabsorption, this decrease serum calcium level and phosphate level. Once calcium level decreases, phosphate level also decreases. So inhibit osteoclast. So inhibit in the osteoclast, you can say mediated bone reabsorption. In that condition, decrease serum calcium and phosphorus level or phosphate level. Promotes renal excretion of calcium and phosphate. How? What are the effects? You can see the calcitonin necessary for biological activity, and the C-terminal portion of the molecule, which is proline-amide residue, and the disulfide bond between cysteine 1 and 7 and the met residue at position 8. This is the diagrammatic representation in the previous slide. This is all including in that one. Used as a potential treatment for hypercalcemia. Potential treatment for hypercalcemia are 7 transmembrane segment receptor and stimulate CAMP production of bone and kidney. So these are the important function of calcitonin for calcium homeostasis. Calcium sensing receptor, these are the important function, and this is the extracellular and this is the intracellular. This is the acidic COOH. So parathyroid chip cells contain calcium sensing receptor. We used to call CASR, calcium or sensing receptor. So this is the CA means calcium and SR means sensing receptor. So these sensing receptor contains 7 transmembrane segment, affinity for calcium, and GPCR of the GPLC and G1 variety. These are the contains and generates inositol 1,4,5 triphosphate, which increase intracellular calcium, increase extracellular. So that's why it has mentioned extracellular and intracellular here. So it increase intracellular calcium. There are 2 paradoxes. Receptor respond to decreased concentration of agonist, and low extracellular calcium increase intracellular calcium. This is the factor responsible to maintain the calcium level. So also found in thyroid, C cells, calcitonin, kidney, and brain. So these are the factors responsible for that one. So PTH proprotein, PTHRP, parathyroid hormone related protein. It is synthesized as a 3 isoform as a result of alternative splicing 139, 141, 173 amino acid. These are the synthesized as a 3 isoforms. What? Parathyroid hormone related protein. Parathyroid hormones related protein. So better to underline this one because this is the MCQ question. So this is the parathyroid hormone related protein synthesized as a 3 isoform. What are the alternative splicing? 139, 141, 173 amino acid. This is the isoforms. So can activate the parathyroid receptor, play a physiological role in lactation, possibly as a hormone for the mobilization or transfer of calcium to the milk, because this is related with the calcium biological function. So parathyroid hormone related protein is also responsible to maintain the calcium level, which is known by calcium homeostasis. Now parathyroid membrane PTH-RP related protein continue may be important for fetal development, but causes, exact cause, and it has, we cannot say this is the important for the fetal development. No, that's why here it has mentioned may be important in the fetal development. So may play a role in the development of humoral hypercalcemia of malignancy, or in the short form you can say HMM. So PTHRP continue still, and squamous cell cancer are associated with hypercalcemia. Other cancer which is very known, multiple myeloma, lymphomas, and breast cancer can be associated with hypercalcemia. So maintain the PTH RP also. So this is the continuous. So PTH RP parathyroid related protein is very important. Now you can see this is the sequence highly conserved region PTH RP parathyroid hormone related proteins, highly conserved region. You can see the alpha 1, this is the PTH-like activity, and 24 to 28 hypotensive activity. After that, PTH-like activity, it will go from the amino acid 1 to 14, and PTH and PTH-RP, parathyroid-related protein, these are the condition. That's why sequence, it was there in the previous slides. So later on also you can see the placental calcium transfer, basic residue, rich region, and osteostatin, osteoclast inhibition, specific non-conservative region, and present to one of the three isoform. These are the factors which are very much important for PTH-RP, which is known by parathyroid-related protein. This is the diagrammatic representation, which is not very much important for the explanation for that. So physiological adjustment to hypo and hypercalcemia, how it can be maintained in our hyper condition also, and hypo condition and also, and hyper condition also. Whenever it will be in our body, suppose here you can see stimulation of PTH here, decrease in plasma calcium level. Whenever decrease the plasma calcium level, stimulate the PTH secretion. Once stimulate the stimulation of PTH secretion, it will go to the kidney, increase calcium reabsorption, and increase synthesis of 125-OH D3, which is known by calcitriol. So this one is very much useful for increase the plasma calcium level. Once increase the plasma calcium level, calcitonin secretion will start. Once start the calcitonin, it will come to the decrease in that condition, intestine, it will come to the intestine and increase the calcium absorption. And in that condition, you can see here, decreased plasma calcium level, stimulation of PTH secretion, it will come to the kidney and also in the bone, and once it will come to the bone, increase calcium reabsorption. And calcitonin secretion, in that condition, you can see the bone increase calcium reabsorption. So three conditions you have to keep in your mind. For physiological adjustment to hypo and hypercalcemia, how it can we work to maintain the calcium level as well as the phosphate level in the important organ related with the intestine, kidney and bone, and how it can be regulate with the factor which is known by D3, calcitonin and PTH. So once it will start the calcitonin, suppose here, maintain the hyper and hypocalcemia, how it can be work. So calcitonin secretion, first of all, in our body generally, it is whatever we are taking in the diet, it will movement will be from here intestine. Intestine means what will happen? Increase calcium absorption, increased calcium level. So from kidney, a stimulation of PTA secretion, it will come to the kidney, increase calcium reabsorption, increase synthesis of 125 means calcitriol, and after that it will move to the intestine where increase calcium absorption and stimulation of PTA secretion. It will come to the kidney, then it will movement will be intestine, and then after that it will come to the bone, increase calcium reabsorption. Once the kidney will kidney is transferred in the intestine and working increase plasma calcium level, and in that condition in intestine increase plasma calcium level, and from bone also increase plasma calcium level. Once increase plasma calcium level, it means calcitonin secretion will be there. Once increase the calcium secretion, it will come to the intestine, then the stimulation of PTA secretion, decrease plasma. These are the mechanisms behind that. Now you can see the explanation for that. Hypocalcemia stimulates both parathyroid hormone PTH release and PTA synthesis. And both hypocalcemia and PTH increase the activity of the 1-alpha hydroxylase enzyme in the proximal tubular, or PT also cell of the nephron, which increase the synthesis of 125 hydroxy vitamin D calcitriol. Or only you can write, if you are forget to write, remember calcitriol, better to write the calcitriol. Now PTH increases bone reabsorption by osteoclasts. This is the mechanism behind that, and PTH and calcitriol stimulate calcium reabsorption in the distal convoluted tubule, which is known by DCT. So calcitriol increase the fractional absorption of the dietary calcium by the GI tract. This is the important point for that. And all these mechanisms add in the returning the serum calcium to normal level. Because of that, these are the factors which maintain the absorption, transportation, and function of the to maintain the calcium. Now, this is the one of the factors which is very much important to maintain the calcium, playing vital role for calcium homeostasis. And this is the one of the factor. Apart from the other things, we had discussed several things, but 3 factors are responsible to maintain the calcium homeostasis. One is vitamin D, which is known by calcitriol also, 125D all 3, calcitonin also, and PTH also. So how it can be mechanized, all the things, what are the reaction behind that? From the skin, cholecalciferol, which is known by vitamin D3, and D3 25 dihydroxylase along with the 25 dihydroxylase from the liver, it will inhibition will be there, and 25 hydroxycholecalciferol will be there. So 25 hydroxycholecalciferol, it will act in the liver, it is inhibition will be there. So 25 hydroxycholecalciferol, it will come to the kidney, and here 1-hydroxylase enzyme action will be there. So there will be first step 25 hydroxylase, in the second step 1-hydroxylase, and there in the first step in the liver, second step in the kidney. So parathyroid hormone activation in the kidney. Once activation will be there, so complete 125 dihydroxycholecalciferol will be there. So this site is in intestinal epithelium. So in that intestinal epithelium, 3 hormones, which is calcium binding protein, calcium stimulated ATPase, and alkaline phosphate, are responsible for intestinal epithelium. Once intestinal epithelium, calcium binding protein, calcium stimulated ATPase, and alkaline phosphate will be there. So it will move to the intestinal absorption of calcium. And here plasma calcium ion concentration. Once plasma calcium ion concentration will be there, inhibition taking place and parathyroid hormone will secrete, activation will be there. So in the kidney with the 1-hydroxylase enzyme, these activities which here with the arrow I have given here, this is the activity, whatever it has been given, this is the mechanism behind. Either of the two things, either explain over this diagrammatic representation or single explain that one, this one. Either of the two, if you are giving, both are same. So effect of other hormones on calcium metabolism, which has been discussed. This is the glucocorticoids we had discussed. No need to discuss right now here, along with the other hormones. And I said in the beginning only three factors, some of the hormones responsible to maintain the calcium homeostatic, calcium level in our body. So sometimes it is very much helpful to increase the calcium level. So one of the factors is glucocorticoids, lower serum calcium level by inhibiting osteoclast formation and activity. So during the osteoclast activity, serum calcium level will be decreased in that condition. So over a long period, they cause osteoporosis. And by decreasing bone formation and increasing bone reabsorption. So glucocorticoids is playing vital role for the maintain the calcium homeostasis. They also decrease the absorption of calcium from the intestine by an antivitamin D action and increase its renal excretion. These are the factors. And growth hormones also, this one I said, thyroid hormone, estrogens, insulin, these are the factors which are responsible to maintain the calcium level in our blood or in our body. So these are the factors which are responsible to maintain compensation quotient. Now, this is the question is very important, very important. You can go through it once. A 55 years old patient complained of muscle weakness first, fatigue, and depression. She had a recent episode of renal stone and a bone scan revealed osteopenia. She had not yet entered menopause. She has taken a daily multivitamin tablet plus an additional 500 milligrams of calcium citrate for the past 20 years. Result from blood chemistry analysis indicated elevated level of serum calcium ion. Urine analysis indicated phosphaturia, and the patient symptoms are most likely caused by which of the following? Can you explain this question, PBQ question? It is related with this calcium homeostasis. Can you explain what is the possible diagnosis? Hello? Hello? Hello?
Yes, sir.
Can you explain? Why responding very late? Huh? Huh? Can you elaborate with the clinical sign and symptoms and diagnosis? Note it down, discuss along with your friend, and again we will discuss. Is it? If we will get the time. Is it okay? This is related with the calcium homeostasis. It's okay?
Yes, sir.
Okay. Should I move forward now?
Yes. Yes, sir.
Should I go ahead?
Yes, sir.
See, the excessive intake of vitamin, if you are taking, these are the factors. Excessive intake of vitamin D, excess synthesis of parathyroid hormone, excessive intake of calcium, excess synthesis of calcitonin, excess intake of phosphate. These are the factors relatively concerned with this PVQ question. These are relatively concerned with this previous slide. This is the related with the PVQ question. So these are the factor, these are the helping point to solve that question. So along with this clue, you can discuss with your friends. Okay. So this is the before the introduction of vitamin D. 45 milk children who spend most of their time indoors often developed rickets. In these vitamin D deficient children, the most likely explanation for their bone malformation in which of the following: excessive renal excretion of calcium, excessive renal excretion of phosphate, and inadequate uptake of calcium in the intestine, lack of weight bearing exercise, excessive renal tubular reabsorption. Among this question, this is the MCQ question. Which one is correct answer? Which one is correct answer? Hello? 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 हेलो क्या हो रहा था बच्चे